Hi, my name's Jonathan Singer. I'm a professor of social work at Loyola University Chicago, and I'm really glad to be able to take a minute to provide a high level overview of suicide in the United States. Now, whenever I talk about suicide, I recognize that most of us think about suicide as the interaction that we have with an individual who's in a suicidal crisis, or a parent of somebody who's suicidal, or even somebody who's lost someone to suicide. Those are all very micro, individual level interactions. And so I like to start every presentation by acknowledging that suicide is a social and a structural issue, and if we want a world where people feel like their lives are worth living, we can't have a society that says that some lives are worth more than others. And I share this, and I could spend hours talking about the structural implications. But as I go through and I talk about some of the statistics, some of the warning signs, protective factors, some of the ways that we assess and intervene and address postvention, I want you to keep in mind that all of these have ramifications for structural level issues. Um, and so let's get into it. So, Jerry Reed, social worker and somebody who's been involved in suicide prevention for many years, says that behind every statistic is a tear. And I think this is absolutely true in suicide. In 2021, which is the last year that we have the most updated confirmed stats for, we had 48,183 deaths by suicide, which means that there were 132 Americans that died by suicide every day, one death every 10.9 minutes. And there are approximately 1.2 million suicide attempts every year. It's about 15 million people who attempt suicide. Now, when we think about the group with the most media attention in suicide, it's often adolescents. Suicide is the second leading cause of death for youth, and it's the 10th leading cause of death overall. Now, as we can see in this graph, over time, the suicide rate has significantly increased. Uh, Around 2000, it started at about 7, and it went up and down. But starting in 2007, it increased until 2017 when it plateaued, and then it went up till the sort of the in the middle of the first full year of the pandemic, 2021, we can see 11.3 per 100,000. Now, the preliminary data that we have for 2022 suggests that that suicide death rate decreased. And we're not exactly sure why it went up. We're not exactly sure why it went down. But as we think about um, figuring out what's going on with any individual, we have to be aware of things like the warning signs for suicide. What are some of the risk and protective factors? And so I'm going to take a couple of minutes to talk about some of those. So, some warning signs include things like hearing somebody talk about or making plans for suicide, expressing hopelessness about the future, or displaying severe, overwhelming emotional pain or distress. Now, with adolescents, expressing hopelessness and being in intense emotional experiences can be, just a Wednesday. But when you combine that with making statements like, I don't think anybody would care if I lived or I died, or especially if you pair them with some of these worrisome behavioral cues down below, like withdrawing or changing from social connections or situations, and that can include disconnecting from social media. Um, Recent increases in or agitation or hostility, anger or hostility that seems out of character or context, and this could be, somebody that this could be an adult who lashes out at a colleague, or gets into a fight with somebody in a public space, and that's not something that they would ever do, right? Very ego dystonic behavior, and then changes of sleep. So anybody who's has gone several days on 2 or 3 hours of sleep is not going to be functioning well cognitively. They're likely to be experiencing some sort of hallucinations or delusions. They are likely to feel much more anxious about what's going on. And if you pair that with some of these top warning signs, like I don't think anybody would care if I lived or I died, I got into a fight with my boss, I'm no longer on social media, and I've only been sleeping for a couple hours a night, those are warning signs that something is likely to happen in the near future where they would end their life. Now, one of the myths that I always like to address is this idea that suicidal people are weak. And what's true is that people can be suicidal despite enormous strength and courage. And I found this on the internet, and I thought it did a great job of explaining it. And it says that we don't want to confuse my bad days as a sign of weakness. Those are actually the days that I'm fighting my hardest. Now, if we think about any given person, here's an example. I'm going to give two examples. Here's an example of a 16-year-old that I worked with, Leticia. She came to the USA from Honduras with her mom. She lives in an apartment complex with people from Honduras and El Salvador. She had a history of trauma and anxiety, not just stemming from her journey from Honduras to the United States, but before and after. Um, Her mom grounded her because she found out that Leticia was walking home from high school with a boy who lived in the apartment complex, but they were unaccompanied nonetheless. And for the mom, this was a major, major breach of social etiquette. It was not something that she would have done in her little village in Honduras. And Leticia, on the other hand, thought she was being just about as good as any American high schooler could be. They weren't sexually involved. She found him attractive, but they weren't dating, right? She thought she was being respectful culturally. And when her mom grounded her, Leticia attempted suicide. We worked together for an intensive 30 days, and we looked at the relationship between the mom and the daughter. We looked at the acculturation issues and different expectations. And 2 years after I finished working with her, I got a graduation announcement. And it was one of the most powerful and profound graduation announcements I had ever gotten, because it suggested that not only had she lived, but she'd really found this purpose. And that was really powerful. Um, the the next example that I'm going to give is Mike. And Mike is a 52-year-old white male college professor who was born and raised in Chicago, lived in Oak Park with his wife and three kids. He had a history of depression and substance use, and he died by suicide at age 20 in 2021. Mike was my colleague. His death was a shock to all of us. We knew that he had been struggling, but he had been doing everything that we would say somebody should do. He'd been reaching out. He'd seen a therapist. He had been able to really utilize the healthcare system. But as it turns out, he was experiencing depression with paranoia. And this was something that we didn't put together until after he died. Now, the risk factors for Mike and Leticia are very different. We've got age, we've got race, we've got ethnicity, but suicide was something that they both shared in common. And so when you look at people and you try to understand their social and their cultural contexts, you understand the access to resources. All of these can play a part in what's going on in terms of both identifying and responding to suicide risk. So I want to take a minute to talk about prevention, assessment, intervention, and postvention. Now, one of the biggest myths in suicide prevention is that if you ask somebody about suicide, you'll put the idea into their head. And in fact, asking somebody about suicide will not make them suicidal. And we know this empirically, and we know this anecdotally. The picture on this slide is to the second edition of my book, Suicide in Schools, which comes out December of 2023. We made the desk purple to match the cover, but also to acknowledge that there's likely to be one person, or maybe more than one person, but there's somebody that's suicidal, and we won't know unless we ask. Now, we know anecdotally through years of therapists asking clients if they're suicidal, and that actually resulting in clients getting help, right? That doesn't make them suicidal. But in this classic 2005 publication, Maddie Gould described an experiment that she did where she had a survey of middle school students asking them about recent suicidal thoughts and behaviors. And before they responded to the survey, she had a survey about level of distress, and then they followed up with a kind of a post test afterwards with the same questions, and then she followed up 2 days later. And what she found was that the kids who said that they had recently been suicidal reported higher levels of distress before the survey and lower levels of distress after the survey, and that 2 days later their level of stress remained low. The students that reported no recent suicidal thoughts or behaviors started the survey with low distress and ended the survey with low distress. And so what this meant, which is amazing, and these results have been replicated for years. There was a systematic review that found this, these are very robust findings, was that for folks that had recently been suicidal, asking about suicide actually resulted in decreasing distress, and it did not increase distress or suicide risk for those who reported not being recently suicidal. So, the next time you're talking with somebody and you're wondering, "Oh, I wonder, given what's going on, they've just had a bad breakup, or they've just lost their job, or they've just recently their spouse has died. I wonder if they're thinking about suicide." There's probably going to be part of your brain that says, "Ooh, I don't know. I don't know if you should ask, because if they're not, like, you might put the idea into their head." Just thank that part of your brain that is bringing that up and say, "I appreciate it. Thanks for looking out for me, but actually it's better to ask and then act if necessary." Um, Now, when you assess for risk, the whole point of a suicide risk assessment is to understand the story of how and why somebody became suicidal. For a long time, I was trained in this, and I trained people to think about suicide risk assessment as a predictive device. Lots of states say a suicide risk assessment is valid for 48 hours, meaning that if you assess me, I should be able to predict what I can do for the next 48 hours. Well, we know that that's not true. We've known that clinically for years. And so I like how Tony Pisani and his colleagues out of University of Rochester are conceptualizing this, which is suicide risk assessment as a way of identifying points of prevention rather than prediction. So after the suicide risk assessment, the social worker, as well as the client and the family and friends who are sort of involved in their social environment, should know which stressors or conditions might exacerbate the current suicide risk and have a plan for preventing those from happening, right? And this is in contrast with the traditional view of the suicide risk assessment as a tool for predicting what's going to happen in the near future. I might know that my client, let's say, is a 15-year-old who says that if my parents take my phone away, that's going to increase my suicide risk. Whether you agree with that or not, that's something that you know. And so you can work with the parents on a plan to reduce the risk associated with removing the phone. The parents still might remove the phone. That might be an appropriate response. But being able to reduce the phone, having a plan is a way of prevention. Not You can't predict if they're going to remove the phone, but planning is important. Also, asking a simple question like, "How confident are you that you're going to be able to keep yourself from attempting suicide?" has been shown to correlate with future suicide attempts. So, youth who were recently hospitalized for suicide attempt were asked this question, and those that said they were extremely confident were significantly less likely to attempt within the next 6 months than youth who said they were not very confident. Now, there are lots of interventions out there. This is specifically for schools, but it's not exclusive for schools. So there are universal prevention programs that are out there. And then there are what we call tier two, which are kind of these selective interventions. Then there's tier three, which are for kids that are actually suicidal. And if you're thinking about adults, you can think the same things, right? So what are things that we can do in the workplaces? What can we do with older adults? For all of them, they can reduce risk. And then these tier 4, 5, and 6, these are really outpatient, residential, and inpatient settings. And there's a lot of empirically supported interventions for suicidal folks. You've got attachment-based family therapy, you've got dialectical behavior therapy, suicide CBT for suicide prevention, a whole bunch of interventions that have been shown to be effective. Now, in tier 3, you can see safety planning, and safety planning is something that I think everybody should do. This is a clip of the safety planning that we developed for our second edition of the book. We call it a home school safety plan. I'm showing this to say that you can modify safety plans to meet the needs of the situation. What we found was that folks were doing safety planning in school where they were really helping kids to identify ways to decrease the distress associated with suicidal thoughts. Um, and and those are things that you can do by yourself to distract yourself, places you can go, or people that you can enlist to help distract you. And that they were identifying things, maybe things that they could do at home, but it didn't really work well at school. You can think about that if somebody's in a residential setting, um, any place where there's multiple environments that they're in. Can think about creating these distractors in more than one environment. So that's what we did here. Um, After you create these things, after you identify them, then you want to rank order the list, right? Which is on the next second half of the page. And then there are things that you can do to keep your environment safe. And this gets into what we call in suicide prevention uh, uh, means restriction. And means restriction is actually a very powerful way of preventing suicide. It doesn't address the underlying issues associated with why somebody might want to kill themselves. But one of the best ways of restricting access to lethal means is restricting access to firearms. Um, the majority of suicide deaths are by firearms. 2/3 of all firearm deaths are by suicide. If we were to eliminate firearms in the United States tomorrow, we would cut suicide in half. And we would reduce it by over 70% for white males. Now, uh, this is not likely to happen anytime soon because of the politics and the Constitution of the United States, but suffice it to say, it's important to acknowledge if we're thinking about these broader level, structural level issues, and suicide prevention. If you want to prevent suicide by gun, research has shown that one of the best things that you can do is to pass legislation that's focused on preventing gun ownership rather than regulation of the use and storage of guns that have already been acquired. And this is by research by Mike Anestis and colleagues. They did follow-up research during the pandemic, and they found that the majority of first-time firearm purchasers, because there was sort of more first-time purchasers purchased guns in the beginning of the pandemic than at any other time, they found that there was an increased risk for suicide by firearm from those first-time gun purchasers than by folks who already had guns prior to the pandemic. Now, once somebody dies by suicide, the message that we have in suicidology really shifts from, how can we prevent suicide? What are ways that we can see this as a preventable public health problem to focusing on the grief and the loss? And the word that we use for that is postvention, intervening after a suicide death. In order to address grief and loss and also to prevent future suicide deaths. Now, research has shown that postvention is effective at addressing grief and loss, including traumatic loss, but there's no evidence that postvention is effective at preventing suicide deaths. And in part, this is a methodological issue, but in part, it could just be that postvention really does better on grief and loss. Now, I was talking with Sade Heart of the Hawk Ali, who is a two-spirit elder, now ancestor. She transitioned last year. And she said that, postvention is most effective when it's planned for and is respectful of the cultural variations associated with grief and loss. And specifically, she shared this idea that you want to step into a cultural bubble without breaking it, which I found incredibly powerful. So I wanted to share that with you. Now, as I end this presentation, I just want to end with resources. So, of course, there's 988, Suicide and Crisis Lifeline. There's the Trans Lifeline, which is not part of 988 because 988, about 1% to 2% of the time, engages in what they call active rescue, where they will call somebody out to the caller's home to intervene. And because of what we know about the negative interactions between law enforcement and trans folk, Trans Lifeline does not support active rescue. There's also Trevor Project for queer youth. There's Crisis Text Line, which anybody can use, and it's available in 5 languages. And if you have teenagers, there's something called Teen Line and Youth Line. There are about 6 of them around the country where you have teenagers addressing crisis calls for other teenagers. It's pretty amazing. There are lots of resources out there. Since you're going to have this presentation, I'm just going to quickly go through these. I appreciate the fact that you all are embarking on this project to integrate suicide prevention into your curricula. And it's been an honor and pleasure talking with you today. So thank you so much.